I'm going to talk about the updates on central nervous system tumors. Again, this presentation I prepared together with my mentor, Professor Patricia Tai, and the other co-authors, which I again have mentioned here. So we declare no conflict of interest. And now we know that central nervous system tumors represent a complex and diverse group of neoplasms that pose significant challenges in diagnosis and treatment. Now, central nervous system tumors may be divided into primary and secondary. Secondary being metastatic tumors, and they are quite common in patients. Now, over the past decade, notable advancements have been made in treating these tumors. A comprehensive literature review was conducted using PubMed and major conference proceedings from the past 10 years. And the results from this study showed that there has been a significant advancements in systemic therapy. Now, one new drug which has been FDA approved is vorasidenib. Vorasidenib was trialed in and tested in Indigo trials in 2023. Now, vorasidenib is an oral brain-penetrating inhibitor of mutant IDH1 and 2 enzymes in patients with IDH-mutated gliomas. Now, this trial took 340 patients who had grade 2 gliomas, and they were divided into two groups, one which took vorasidenib and the other which took placebo. Now, patient had measurable non-enhancing disease assessed centrally and had undergone surgery. They had not received any post-operative treatment, and after a median of 3 years from histological diagnosis, they were included in the trial. Now, the primary endpoint of the was progression-free survival. After a median follow-up of 14.2 months, 226 patients were still receiving vorasidenib or placebo. Progression-free survival was significantly better in the group which took vorasidenib compared to the group which took placebo. Another thing which had been noted is that patients who took vorasidenib went almost 28 months without any tumor growth, compared to the group which took the placebo, who only went 11 months without tumor growth. Another thing which was noted is that vorasidenib was well tolerated. Grade 3 or higher adverse events occurred in 22.8% of cases, and the most common adverse effect was an increase in alanine aminotransferase, which occurred in 9.6% of patients who received vorasidenib. Another FDA-approved drug is tovorafenib, who had been used in refractory or relapsed pediatric low-grade gliomas harboring a BRAF fusion or rearrangement and BRAF V600 mutations. Now, tovorafenib was tested in the Firefly-1 trial, which included 76 patients who took this drug. Now, excluding criteria here were tumors harboring additional mutations like IDH1 or 2 mutations, FGFR, and so on, and also patients who were suspected to have neurofibromatosis type 1. Now, tovorafenib was given orally once per week based on body surface area. The major efficacy outcome measure was overall response rate, which was 51%, defined as a proportion of patients with complete response, partial response, and minor response by blinded independent central review. Additional efficacy outcomes measured include median duration of response. The most common adverse reactions which were seen in tovorafenib were rash, hair color change, fatigue, hemorrhage, headaches, viral infections, and so on. Also, the trial saw some grade 3 and 4 laboratory abnormalities, which included decreased electrolytes like phosphates, sodium, potassium, and also a decrease in albumins, lymphocytes, leukocytes, hemoglobin, and so on. Also, there was an increase in alanine and aspartate aminotransferase and creatine phosphokinase. The recommended dose of tovorafenib was 380 milligrams per square meter orally once per week, but this dose could go up until 600 milligrams. Now, another trial which focused on radiotherapy was the Quartz trial. It was a randomized phase 3 non-inferiority trial involving 538 patients with non-small cell lung cancers and brain metastases who were not eligible for surgery or stereotactic radiotherapy. Now, the patients were divided into two groups, one which took optimal supportive care, including dexamethasone, versus the other group who took optimal supportive care together with whole brain radiation therapy. Now, the dose of dexamethasone was determined based on the patient's symptoms. Outcomes from this study were measured using quality-adjusted life years. Also, they saw overall survivorship and quality of life. The results from this study showed that there was no difference in overall survival, overall quality of life, or dexamethasone use between the two groups. Now, the difference between the mean quality of life adjusted life years was 4.7 days. 46.4 days in the group who took whole brain radiation therapy and 41.7 in the other group. There was no significant difference in overall survivorship, and also the group who took whole brain radiation therapy had more side effects. Another parameter which has been introduced is brain metastasis velocity, which basically means the new number of new brain metastases that develop after the first SRS divided by time since the initial SRS. So patients were classified based on BMV into three groups, them with a low, intermediate, and high risk groups. Now, the low risk group were the group who had less than 6 new metastases per year. 6 to 15 were them with new metastases per year were in the intermediate group, and over 50 new metastases were in the high risk group. Now, factors assessed for effect of BMV included histology, number of metastases at time of first SRS, and systemic disease status. BMV, now there was a correlation between overall survivorship and BMV, we saw that in the low, intermediate, and high risk groups, the overall survival was 12.4 and 8 months. So the overall survival was lower in the groups who had a high risk BMV. Also, it was seen that patients with who had HER2 positive breast cancer were more predictive of lower BMVs, and melanoma patients had a higher BMV. Now, median BMV for breast, lung, renal cancer, and melanomas were 4.3, 5.4, 6, and 9.2 new metastases per year. Also, neurological death was linked to a higher BMV. Now, another trial was the NRG oncology phase 3 trial, which looked at patients who had whole brain radiation therapy, and another one who also had whole brain radiation therapy, except they avoided the hippocampus. Now, the aim of this study was to see if the group who avoided the hippocampus had better cognitive functions after some time. Now, the results showed that the group who avoided the hippocampus had better executive functions after 4 months, and also learning and memory were better in this group compared to the standard whole brain radiation therapy group. As far as overall survival, in intracranial progression-free survival and treatment-related toxicities, they were the same, but the only difference was in cognitive functions. Another test another trial which was done took three groups. One which took SRT before immunotherapy, another which took them at the same time, and the other one who took SRT after immunotherapy. Now, they focused on overall survival, regional progression-free interval, and treatment toxicity. Median OS was 18 months, and OS after 1 and 2 years were the same in the three groups. Now, the progression-free survival was highest in the group who took both SRT and immunotherapy at the same time, and the lowest was in the group who took SRT before immunotherapy. Now, local progression-free interval after 1 year was high in all three groups, which tells us that SRT is effective at controlling the treated lesions no matter when it's given. There was no significant increase in side effects in any of the three groups, and neurological toxicity and radionecrosis rates were low and similar across three groups. Now here in this figure, I've shown a single isocentered modulated arc therapy. And so basically this, there was a experiment or study which took a single isocentered VMAT and compared it to gamma knife to see which one is better. And it turned out that they are quite similar. And in fact, in some cases, the single isocentered VMAT showed it was a little bit better than gamma knife. Now another treatment method is TT fields. They are non-invasive regional anti-mitotic therapy, which deliver low intensity and intermediate frequency alternating electric fields. Now, they work by disrupting spindle formation, dielectrophoretic disruption, and DNA and replication stress. Now, in one trial, they took these TT fields and compared them to the best chemotherapy at the time to treat glioblastoma. And the results showed that TT fields were just as effective as chemotherapy. However, they had less side effects. And another trial took patients who had first undergone surgery or biopsy, then chemoradiation with temozolomide. Then they were divided into two groups, one which only took TMZ and the other which took TMZ, and also they had TT fields used. Now, median progression-free survival, median OS, and 5-year survival rate were higher in the group who underwent TT fields and TMZ together. And this led to it being FDA approved in 2015. And a new study which is being trialed right now in the PAN trial is the use of oncolytic herpes simplex virus in treatment of high-grade gliomas. Now, the PAN trial employs a genetically engineered oncolytic herpes simplex virus type 1 designed with dual payload genes. So one encoding human interleukin 12, which enhances immune activation, and another one which is anti-PD-1 antibody fragments, which help counteract immune suppression in the tumor microenvironment. Now, this dual mechanism is intended to convert cold tumors into hot tumors, which is a significant challenge in treatment of glioblastomas. The implantation of a pump that enables repeated doses, allowing both priming and boosting doses of the immunotherapeutic agent is a new technique. And also this approach aims to enhance repetitive tumor targeting while reducing systemic exposure and associated toxicity. Now, as a conclusion, we see that in these past years, there have been substantial advancement in systemic and radiation therapies, which included improved CNS tumor care, increased overall survival, and decreased of side effects. Ongoing research into earlier diagnosis, personalized treatment, and quality of life optimizations remain crucial. Now, here again, I want to thank Björn Baumann, Rashmi Kul, Jake Van Dyke, Kurian Joseph, and also my professor, Patricia Tai, who made this possible. Thank you.